Well, today I'm delighted to welcome you to this Ground Round lecture. Today we will have a very interesting lecture from Dr. Laeequa Qazi of artificial intelligence and its impact on the future of anesthesia. For those who don't know me, I'm Dr. Juan Carlos Silva from Venezuela. I'm an anesthesia consultant working here since 2018. And today I'm very happy and proud to introduce a colleague and a dear friend, Dr. Laeequa. For those who don't know her, she's from Pakistan. After she completed her diploma in anesthesia in 2005, she completed her anesthesia fellowship degree in College of Physicians and Surgeons in Karachi. In 2012, she joined our loved hospital, where she passed all the processes for the Saudi Commission of Health. And finally, in 2021, she joined the anesthesia department as a consultant. So we are in the presence of an extraordinary professional, a real colleague that have been immersed of the world of ophthalmic anesthesia for the last 12 years. So today, I will thank her for accepting the invitation to this Grand Round and for share all the knowledge and expertise she has. So as you may know, nowadays, artificial intelligence has been revolutionizing the medicine, and anesthesia is not an exception. Today, I will introduce how artificial intelligence has been used to improve efficiency, safety, and the well-being of the patients in every field of medicine. But in this case, we will see the impact in ophthalmic anesthesia. So Dr. Laeequa will cover very important topics that are now in our field, such as how to predict risk complications with the use of artificial intelligence. She will introduce us how is the new development of personalized anesthesia system like robotics for intubation. And well, I would like now to let Dr. Laeequa to come here.
Facing a big medical problem. A growing number of patients and not enough doctors to treat them. So could artificial intelligence be the cure?
I feel like I'm working at the forefront of something that could potentially be revolutionary to healthcare in the future.
AI has the power to transform the ways patients are diagnosed and treated.
And we think it'll become a game changer.
And to make the testing of new medical procedures more efficient and effective.
And if we can get devices that can be developed faster, better, and quicker, then there are huge benefits.
Good afternoon. Thank you so much, Dr. Silva, for such a good introduction. So today, as you know, that I will start talking about the artificial intelligence and its impact on the future of anesthesia. So before starting the main topic, I will just give a brief introduction of artificial intelligence. So artificial intelligence is the broad concept of machines designed to understand and perform tasks on their own. They do this in a very smart manner. It refers to any human-like behavior displayed by a machine or a system. In artificial intelligence, the most common form are the computers. These computers are programmed to mimic a human behavior using extensive data from the past examples of the similar examples and behavior. It gives the machine the ability to reason and perform functions such as problem solving, object, word recognition, interference of the word states, and decision making. There are two types of artificial intelligence: the artificial intelligence based on functionality and artificial intelligence based on capabilities. Based on functionalities has the subsets known as reactive machine artificial intelligence. This kind of artificial intelligence does not have any past memory or data saved. So it works, but it is not depending on the past data. So they will give you the examples for the future only. The limited theory artificial intelligence has the past data stored, and with the use of this past data and the new combination of data, it gives a good response and good results. Theory of mind artificial intelligence. This kind of artificial intelligence is still under development, and the goal of this artificial intelligence is having a deep understanding of human minds, which is still, I think, under process. Self-aware artificial intelligence. This is also a kind of artificial intelligence in which the things or the equipments will produce its own emotions, could understand and evoke human emotions as well. We can get examples of robotics in this. Based on the capabilities, the artificial narrow intelligence is the artificial narrow intelligence. It has a combination of the reactive and the limited theory artificial intelligence. This is a system that performs narrowly defined program tasks. Like in the common daily use, we can see we are using GPS machines, the electronic cars. So they can be example of this kind of artificial intelligence. Artificial general intelligence. These are capable of training, learning, understanding, and performing human-like tasks. So the robotics nowadays they are under development also, and we have also. So they are working on this kind of functions. Artificial superintelligence. As the name shows, this kind of artificial intelligence is still under process of being developed. The thought behind this kind of artificial intelligence is that it will perform better tasks than the humans due to its superior data processing, memory, and decision-making abilities. So the artificial intelligence help us in predicting and adapting capabilities, independent decision-making, human cognition imitation, scope of a continuous learning, mundane task automation, and human augmentation. So with the help of this mundane task, we can use this artificial intelligence in our daily works also, planning for the groceries, going for any meetings or anything. It helps us a lot in this situation. As we know, since past 1 decade, the artificial is growing very fast in the medical field. So it is also helpful in anesthesia. It will revolutionize various aspects of the anesthetic applications also. So now we come to the impact of artificial intelligence in anesthesiology. As most of us know that anesthesiologists are the multitasking involved in troubleshooting, monitors, scribing the case records, and performing clinical procedures in the operating rooms. AI helps to handle this wealth of information. In collaboration with the computer scientists, the computation, predictive analysis, and automation can be done in a better way to deliver anesthetic drugs in decision-making and day-to-day critical care in anesthesia. A mature technology can be employed in the anesthesia in which computer can be programmed to simulate cognitive functions of the human mind, such as collection and analysis of data with a focus on model-dependent development and pattern detection to make intelligent predictions. Actions can be modified on the previous experience in the program is designed so that it can learn from its experience. And I think most of us are familiar, like in this hospital, in the ophthalmic setup, we have this track care system. So it's helping us a lot. because we can get the previous history of the patient from that, any complication happens or any drug reaction. So it helps us a lot to make a decision for the future of the patient. Like if we are going to plan for any kind of anesthesia, this past data help us to make a better decision, and there will be less complications. Technological advancement and automation has dramatically developed the anesthetists to reduce the risk of complications associated with anesthesia care, to provide better patient safety and environment to the anesthetist. So with the help of the artificial intelligence, perioperatively, we can identify patients at the risk, early detection of the complications can be done, and timely and effective treatment is done. So as we see from the picture, the healthcare provider is happy and the patient is also happy. So what are the, now we will come to the applications of artificial intelligence in anesthesiology. I think most of us, we are familiar because now it is in every field of the medicine. They have the artificial intelligence is depending upon the various subsets, including machine learning, neural network, deep learning, robotics, and computer vision. So with the help of all this, perioperatively, we can predict the events and risk, depth of anesthesia, delivery of anesthetics, ultrasound-guided regional blocks, pain management, and operating room logistics. Preoperatively, with the help of the events and risk predictions, we can make a better clinical strategies. The artificial intelligence produced algorithms help us to analyze patient medical history, vital signs, and other data to predict their risk of complication during surgery. Preoperative and post-induction hypotension, hypertension, and other complications can be thought of. Postoperative morbidity and mortality. It helps anesthesiologists to personalize anesthesia plans and patients who requires more monitoring. Still, the reliability of these models depends upon the quality and the methodology of studies on which they are based, because putting a wrong data or a biased data will produce the biased results. So we can say that, okay, all the artificial intelligence is coming on the way and it's under progress, but still the human beings are more superior to and the medical physicians should be superior thought of. The final decision should be made by the medical physicians. So intraoperatively, it helps in monitoring and anesthesia management. AI system could continuously monitor a patient's vital signs, depth of anesthesia, and other parameters during surgery. Adjustments of anesthetic delivery leading to improved patient outcome and reduced risk of complications. We have some of these equipments in this hospital and we are using from the past few years. Like I can give an example of bispectral index system. These systems have a strip which is placed on the forehead and a monitor which gives us an idea that how deep the patient is sedated. So with the help of this, we can manage, control the specified range and adjustment of infusion rate of anesthetic agent. Another example of kind of a monitor which monitors the brain anesthetic effect is encephalograms. The newly processed encephalograms monitors individual anesthetic agents given. For the cardiovascular system, the monitoring monitors the cardiac output non-invasively. With the help of the arterial lines, the arterial waveforms are analyzed on monitors to preempt any critical events happening, like intraoperative due to blood loss, intraoperative hypertension, or any critical condition the patient is going on. The predictive models of artificial intelligence for intraoperative hypertension with the super learning algorithms has been developed to predict an acute hypotensive episode 10 to 30 minutes prior to the events that are allowing enough time to the anesthesiologist for the intervention. So they are still under development and are used under trials. So it helps the physician to recognize any critical condition 10 to 30 minutes, so they are able to treat this condition in a good time. So for the pain management intraoperatively, analgesia nociception monitors are available. They titrate opioid administration based on changes in sympathetic and parasympathetic systems. They detect opioid-induced respiratory depression by assessment of respiratory rate, pulse oximeter, and mental status of the patient. Investigators have studied irregular breathing pattern intraoperatively and developed algorithm for quantifying breathing pattern and respiratory depression in the post-operative period. So this kind of the monitors are really helpful. We have some of them, but still they are under a process of new technology, and they are coming, and we are also trying to get these monitors, and I think we have requested also for a few of them to be provided, and it will help us a lot, especially here in the ophthalmic surgery, because sometimes the patients, they are the eye surgery is not a big surgery, and the patients, they are usually sometimes and we cannot give them general anesthesia because of the related comorbidity. So with the help of these monitors, it will be really helpful to us that we will provide a good anesthesia care to the patients, and we can give a good sedation, and the patient will be in the good environment and helpful. The analgo score described is used for measuring. So for the pain, there is an analgo score described. It is used for measuring pain during general anesthesia, calculated from the deviation of the patient's target values for heart rate and mean arterial pressure. So with the help of this score, we can detect that whether the patient is feeling pain, and we can increase the dose of the drug depending upon the patient condition. A hybrid sedation system. This system uses respiratory rate and oximetry to outperform manual administration of the anesthetic drugs. Investigators are looking in the feasibility of combining fluid administration along with the appropriate vasopressors used in a single automated system for guiding perioperative care. So with the help of all these systems, as I told you, it will be really helpful for us to provide a good anesthesia care intraoperatively to the patient, and the patient, if there are comorbidities so it will be under control, and the complications can be avoided. So here I will show one video which will tell you that how satisfied the patient with the help of artificial intelligence. They are very satisfied at
You're going to hear that voice, a little vibration, telling you to squeeze the little plastic device.
That voice will be coming from Penny Gilead's anesthesiologist. A computer. Yes, a computer.
Very deep breaths in through your nose, out through your mouth. Okay?
Virginia Mason is the first in the Pacific Northwest and among the first in the country to use the Sedasis machine, which is FDA approved, but only for certain procedures.
It is a very specific niche of patients that we're talking about, relatively healthy patients having colonoscopies and upper GI procedures.
A nurse is there to monitor Penny at all times and to check her vital signs.
It's a dramatic difference.
Dr. Otto Lin says the Sedasis machine allows for the use of a more powerful drug called propofol, which is easier on patients, but also more dangerous to administer. Penny, who's also a registered nurse, is not the least bit fazed.
If anything starts to happen with me physiologically, the machine's going to slow down the infusion so that I wake up and don't progress deeper into sedation, which is where the danger zone is.
Squeeze the handcuff now. Penny is asked to squeeze a controller to measure her response times. Only Dr. Lin can increase the dose. The machine simply puts on the brakes if needed. Before this, Virginia Mason used sedatives administered by a nurse which often left patients nauseous, groggy, and worse. Sometimes they didn't work for everybody.
We no longer have those situations where patients feel like they're inadequately sedated.
Minutes after it's over, Penny is awake.
Do the whole thing. I'm fine. I'm clear-headed.
So if we can see here, if we use such kind of machines here also, if they show the better results, so it will be really help us in this ophthalmic setup, because most of the patients coming, sometimes they have a different kind of comorbidities and we are unable to provide with them full general anesthesia. So with a controlled manner, we can make the patient more calm and peaceful during surgery. So now we come to the robotics. Robotics is also a kind of artificial intelligence. They are mechanical systems capable of interacting with the environment according to the directed interventions. The attractive role in the complex surgery and anesthesia. They are designed to support by automating tasks based on the clinical scenarios and aid in decision making. They free the anesthesiologists from the repetitive technical tasks, allowing them to concentrate on overall assessment and decision making. We have in anesthesia two kinds of robots, pharmacological robots and the mechanical robots. The pharmacological robots are target controlled infusion systems. Their software has built-in pharmacokinetic models of different drugs. They deliver doses to achieve specific plasma levels rapidly and then maintain to a steady level. The newer versions are available, which minimize the fluctuations from the set target to make the gap between the measured and actual variable as small as possible. So we have two kinds of robots, pharmacological robots. They are a single input-output system and the multiple input-output systems. Here in this hospital, we have this single input-output system, and we are using it most commonly, particularly in some patients having comorbidities, to give sedations. So with this system, we can give only one drug, either hypnotic or a muscle relaxant. But with the multiple input-output systems, we can deliver multiple drugs together, and it will improve the hypnosis, analgesia, and muscle relaxant delivery. And there are also researches going on to incorporate hemodynamic feedback mechanism with the promising results. So I think we have also requested for this multiple kind of output system for the delivery. So it will be really appreciated if the hospital administration help us to provide this kind of equipment. The other kind of robots are the mechanical robots. As we know, anesthesia includes a cognitive, even anesthesia, but the medical field all needs a cognitive as well as skill in performing tasks. Mechanical robots, they are designed to address both aspects. So in 2011, they have discovered a Da Vinci surgical system. So this system has also introduced a robotic system for anesthesia. It was the first fiber optic assisted oral and nasal intubation system. Technically, it was difficult because of the suboptical robotic interference due to having multiple arms. But a newer system known as scapular intubated system was introduced. This kind of a robot has a single arm which was controlled by a joystick to guide endotracheal intubation remotely. The successful intubation with this kind of robot were made within 9 simulated cases that was done within 40 to 60 seconds. So here, if you can see this.
Yeah, that's good. Perfect.
So this kind of things can revolutionize the anesthesia practice and also help us reducing our daily tasks. Another system is Magellan system. This is, I think, for interest in ophthalmology also, because this is used for the regional anesthesia. These are robotic arms in which the needle are mounted, and with the ultrasound guided guidance, we recognize nerves to decrease which will help us to place the needle correctly, and the anatomical relations are known very well. We have in anesthesia department an ultrasound machine, and now we are trying to not trying, but I think we have already asked for a probe that will help us to give ophthalmic blocks also with the ultrasound guided equipments. Post-operatively, with the help of the AI system, we can manage pain. With the development of wireless intelligent patient control analgesia, early discharge and ambulation in inpatient is now possible. The patient can be closely monitored via video conferences and effective feedback mechanism, impacting healthcare costs and the patient satisfaction in a very positive manner. Research and developments. As we know, AI is still under development, and its efficacy in anesthesia needs further research and validation. AI analyzes large data sets of the patients, data to identify factors that contribute to successful or unsuccessful anesthesia. This information could be used to develop new and improved anesthesia technique. Preoperative cognitive robots used for the detection of abnormal laboratory findings, ensuring drug compliance, and conduct of checklists can improve anesthesia techniques. Clinical decision support systems, whether knowledge-based with built-in algorithms or non-knowledge-based, are designed to provide cognitive aids to anesthetists. Deep neural network predictive models for duration of surgeries and anesthesia emergence optimize anesthesia care and streamline operating rooms utilization. I think this kind of AI will be helpful to us in this setup, because most of the time we are complaining that patients are delaying and the turnover time is very long. So if we try to introduce this kind of a system, I think it will be really helpful to us. Post-surgical mortality by using perioperative data, airway assessment, and ability to correctly predict the Cormack-Lehan view on direct laryngoscopy with analysis of face and neck can be made. Intraoperative cognitive robots can be integrated into the alarm systems for simultaneous analysis of the several parameters, thereby lowering the rate of the false alarms. Accurate identification of appropriate prophylactic antibiotics and dosing schedules, efficient gas delivery and billing can be made. Limitation and challenges. Multiple components of AI systems may lead to software failure, whereas incorrect data entry may lead to system failure. Safety checks, possibility to override the system and then return to fully automated mode are important safety considerations. Preoperative data integrated by the AI to produce guidance must be accepted or rejected by the anesthesiologist. So whenever we should not totally rely on these machines, because still they are under development and they cannot bypass the human minds. So any decisions that we see that they are beyond the limits and they cannot be controlled by the machine, we should take in consideration and we should be careful about it. Edge cases are the scenarios where artificial intelligence is unable to perform in an expected manner. So the physician must be able to override automated system whenever necessary. reliance on artificial intelligence should not replace the expertise and judgment of the qualified anesthetist. AI solutions focusing on providing clinical decision support system should not replace the physician judgment. Anesthetist needs to take a call in crisis to follow or ignore AI-based intervention with the medico-legal implications. Validation and understanding of the AI system in clinical care by the clinician is very important to clearly understand and strengthen the flaws of the technology. Now we come to the ethics of artificial intelligence. As we know, AI is an emerging technology with the potential to revolutionize anesthesia care and improve patient outcome. However, its use also raises the ethical concerns related to privacy, transparency, and bias. The responsible development and use of anesthesia AI requires collaboration between the healthcare providers, technology developers, and patients to ensure that technology is using in a way that prioritizes patient safety and equity. It is important to ensure that AI algorithms are developed and tested on diverse population so that patients have control on their own data. AI-based medical research needs a strong regulatory body to weigh in all factors for ethical data privacy. Anesthesiologists must carefully navigate the integration of AI into clinical practice, considering both the safety and ethical dimensions. By providing environment of responsible AI implementation, the field of anesthesia can utilize the full potential of this technology while upholding the highest standard of patient care and the social values. So let's see how far we can take this, and particularly I think in this ophthalmic hospital, with the use of the different kind of the equipments I have introduced, like the robotic pharmacological equipments and computer, with the help of the computer, with a more efficient internet technology, we can look forward for the better patient help, and the healthcare providers can also provide good patient care without any complications. So let's see how we can work together and have a good results. Thank you so much for your patience. So if anyone has any question, they can ask. I think most of us are sleeping because fasting. Sorry, this time is very critical.
How is this going to help us on the changeover time of how it's going to improve the turnover time? The second thing is, will we accept more patients which are referred to the general hospital by using AI?
Yes, with the help of AI, I think we will, particularly as we are discussing every day in our meetings also, like using the this computer, with the help of computer scientists, the IT system, we can make a proper data, we can have a fixed timings, and then look forward for all this previous data, and just take our, with the experience, we will see the turning time, and then we can calculate, make the proper data to reduce this turnover time.
Thank you, Dr. Laeequa, artificial intelligence, I mean, you made up a tour about all the applications of the AI. Many of them are more related with machine learning, no? But AI is a reality, it's present.
Yes.
It's not in the future, it's present. And already has a practical applications, for example, in the financial world, basically creating prediction models, risk management. So if you was a department of anesthesia, what do you think that, I mean, or what are of all these things that we already listen and watch it, which one of these ones can be applicable right now? For example, in research, the way that the research is doing now is totally changed. Basically, how managing data and things, no, and there are actual models of AI that are applicable. So, which of these things we could apply it right now in KKH regarding, for example, risk management, regarding patients or basically risk management.
Yeah, as I have told you regarding these pharmacological robots, if you see these are the gadgets which help us in deliver certain drugs, and I've told you that there is still research. Also, they are trying to introduce hemodynamic parameters in this kind of the gadgets. So with the help of these robots, we will be able, like we are using it, but it's now still they are single drug delivery system, so we cannot use the multiple drugs in this system. And we have, I think recently we also requested for the newer technology which can provide us with a delivery of more than one drug at the same time, and it will also show the vital signs of the patient, so we will be able to control the sedation in these patients, particularly the patients having comorbidities, and we are unable to control them during surgery. And I think even we are using this single drug with the, we are using Presidex for the patients with this delivery system. We called it target control delivery system. So there are improvements going on, and we are looking forward for the new technology also. And we have also asked for this newer kind of equipment. And one more thing, we have requested for this ultrasound guided blocks. We have ultrasound machine here, and now we wanted to utilize this, but we don't have that probe with which the smaller kind of probe with a less frequency, so it will have produce less heat and less harm to the eye. So we have requested for that, and we are looking forward, inshallah, the hospital will help us, and we will be able to do more better way anesthesia.
But let me add something to Dr. Sesma. Right now we have the possibility, for example, to improve the management of high blood pressure. This is an issue that we face daily. More than 60-70% of our patients have a high BP, bad control of the BP. So when the patient arrives to holding area, normally BP is to the sky. So I think these learning machines, the hemodynamic ones, can be attached to the patient and can deliver specific drugs to control BP. So the patient on arrival on holding area, probably BP will be already treated before arriving. Other fields that can be introduced, for example, in this hospital for teaching, and it's simulation and education. I mean, an eye block, it's a very complicated and skilled technique that for teaching must need previous simulation systems that can help the residents and the fellows to learn how to do, because our regular system only allowed them to do 25 to 30 perivolvar blocks, which are not sufficient to be confident. And to finalize, this ultrasound guide with artificial intelligence will be a great opportunity for us and for the hospital to reduce the risk of perforation, retrovulvar hemorrhage, because with this artificial intelligence, you can identify specific anatomy of the eye, and you can target specific places, so the ultrasound will guide you to the safest place where to introduce your needle. Such, in this case, will be a great tool. I mean, so far, it's a tool that requires still the presence of the human being. So far, even in a few research we found on internet, expertise and skills are the main factor for the well-being and the outcome of the patient. So I think, as you said, the future is now. This is a new era for the medical field with artificial intelligence, but we need to be wise in the way we start to use this technology. So far, ethic issues for me are the most complicated and delicate issues related to artificial intelligence, because are you going to allow the machine to treat your son instead of a very good doctor? You trust more on artificial intelligence than your colleagues? Those are difficult topics that have to be included lately. We have to discuss this. But so far, I see artificial intelligence as an amazing helper in prediction complications and to make the possibility to have all the data that you need to make the right decision. But still, we're needed. You cannot let the anesthesia people.
Yeah, but the question is about the predicting models. I mean, do you know any app that already exists for anesthesia for creating predicting models to reduce risk that can be applicable right now in Kekesh?
I mean, for ophthalmic anesthesia, there's nothing. There are for general anesthesia, and depending of the different type of surgeries, you can have hemodynamic predictors for cardiac surgery. You have also neurosensitive predictors for neurological surgery. But for ophthalmic anesthesia, there's nothing applied to it. I mean, we are the ones who have to find which are the tools that are in the market for other subspecialties and accomplish them inside the ophthalmic anesthesia. But ophthalmic anesthesia, as you know, is like the last of the subspecialties that has been approved. So we are facing new challenges that must need the help of artificial intelligence. Dr. Sahur?
Yeah, coming back to Dr. Sesma's question, if I understood it correctly, the artificial intelligence is it is like a more specific. The existing technology and the equipments and the things that we have, the monitors that we have, these monitors are here in the field for the last 40 years. So for example, an infusion pump is not an artificial intelligence because it is there for the last 40 years and it is used, and we know that it infuses the rate and the data that you give it and it works according to that. The real artificial intelligence is that when the machine, you give them a data, you provide some figures or numbers or whatever, and the machine makes decisions for you. The machine automatically bring changes, reduce doses, increase doses. So, but coming back to Dr. Sesma's question, the currently that what we have, the real AI, that is only one thing that we use it some patient, that is bispectral index analysis. And that is what we are currently using, is that we apply the electrodes around the head, and there are some electrodes which monitor the level of the relaxation of the muscles, and plus the EEG waves, and the machine combines these two. It make a calculation and it gives a result in a way that it tells you that what is the depth of the anesthesia for this particular patient and this particular time. So that is probably a real AI at the moment. Dr. Rahman's question was how we can reduce again, I don't think this is possible with the AI in the current situation. I don't know what kind of machine will be there which do the turnaround time or these kind of things. I think these are still more like a manual and human kind of things.
We still need a predictive model.
But let's not confuse the AI with the rest of the technology which is currently in practice and practice for a long time. AI specifically refer to the function where the machine is responsible to make a decision. And you are still there, you are still involved, but it's machine which is, for example, an aeroplane is going in its autopilot. So if the pilot turn on the button as autopilot, the airplane will go, it will land in Heathrow, and unless the pilot interfere and change the direction to any other place. So that is like a good example of an AI. So yes, we expect these to come in future, but probably we are far behind.
I think the humans are needed to put this data. The machines cannot produce their own data. So we are still involved and but still looking forward in future for the better results, as Dr. Zahoor said. And there are limitations, and we should not totally rely on the machines, because putting a biased data or a wrong data can have a very wrong response in the future with a disastrous effect.
But for Dr. Sesma and Dr. Rahiman question, right now I think we have a good chance with the team of IT. If, for example, we use the data we have and we measure the time of the surgery, if we know if it's a complicated, non-complicated surgery, if it's going to be done by a resident or only by a consultant, they can predict the times, they can summarize all this information, and then for scheduling, it's more easy. Because what we face here is someone requests PPB plus FECO, 60 minutes, and in real life, it's 3 hours. Because it's teaching, because the learning process takes time. So of course, we can predict these things with artificial intelligence. We only need to analyze the data we have, and then we can create realistic scheduling programs that make us reduce the time, because what we face is someone books 6 cases expecting to be done in 1 hour, but in real life, it needs 2 to 3 hours. So these kind of things will help. Yes, Dr.
Thank you. It's very interesting and scary. KKH is unique. It's a standalone hospital. We don't. Our major problem is we don't have backup. Do you know how advanced the other standalone hospitals have been in using AI, such as Moorfield or Johns Hopkins?
I have contact with the director of the ophthalmic department in Moorfield, Dr. Andrew Cashman, and they have no use of artificial intelligence yet. Only they are recollecting data. They are creating like a specific data for prediction of risk of peribulbar and subtenon blocks. This is what they are using, and they are using all this data, and they are making the relation between action length, anticoagulants, previous comorbidities, to realize the specific patient that had more risk for each technique. But so far, this is what they are doing. For the rest of the things, for example, the ultra guide with artificial intelligence is still in development for ophthalmic anesthesia. Yes, Dr.
Most of the time, we don't have anesthetists in our ORs in UK, in a local list, and we do give our own subtenants. Only anesthetist is present when you have a GA, which was probably once a quarter in my list, and a sedation perhaps. So we don't have anesthetists doing local anesthesia list. The second point I want to make is that it's a very good topic you chose, because we need to know about how you guys think and how the future of anesthesia would be, and it will certainly improve the patient experience as well as safety of the patients if this is brought into practice. That was my comment.
Thank you very much.
Thank you very much, Dr. Laeequa. It was very interesting subject, but I think the artificial intelligence is not only covering the anesthesia. There is far away, they are doing a lot of things in artificial intelligence in all the fields. And they are now in the Western, they are talking about something what they call post-human. We will be a competitor with the machine, and the machine may win. Finally, I think the machine will win. And the most simple artificial intelligence that we use when we are in the high school is the calculator. The calculator is just an artificial intelligence. But the terminology now, it's become very attracting to people. Artificial intelligence is, I think it's attractive terminology. And I think it's a scary future, as Dr. Hussain said. I wish to live in small village rather than to see this artificial intelligence invading us at home, in the work, in the car, in the street, everywhere. Thank you.
Thank you very much, Dr. Laeequa. It's a great presentation. I just want to make a small comment regarding the data for the, in using AI in any field, you need a ton of amount of data, and you need to also like deep learning or machine learning for the artificial intelligence to give or analyze the data. I think I'm not sure how would you, collect the data or implement this here in KKish.
I think right now, I will give a small example. On the small basis, the TRACS system we are using. Like one patient comes and we know the patients having some kind of a disease, they come most frequently, especially the glaucoma patients or the retina patients, they are coming frequently. So what we do, we just take the history, looking in that system, that how much volume we have given before, or either he has a complication, any comorbidities he having related to complications. So this provides us a good help, and let's see in future if it can be improved more and more fast and to provide them. So only data available is in the track care for us.
Like there is no like imaging or something?
No.
Using the ultrasound that you have in the mail?
Yes, ultrasound we are trying, but we still not used. Once we will get a proper probe for it, that then after that we will see that what's going to be happen. So, but we are still in a way to look for the hospital administration to provide us this probe. Specifically, we have the probe, but it's not suitable for the ophthalmic procedures. So inshallah, hopefully we will get it, and then we will try to.
Thank you so much.
Thank you again for the presentation. And one way of using or utilizing the artificial intelligence is to help with decision. You touched a little bit on that, but if kind of global information is fed into a system, and then we utilize that information to choose what is good for this patient. For instance, is it for local anesthesia? This patient, for instance, we now rely on age and sometimes discussion with the patient that he is for GA or local. Yeah. But if there is some information like profession, he's a medical student, or he's an ophthalmologist, or he's so and so, in addition, gender, previous and systemic diseases and medications he is taking, artificial intelligence can help to decide what to do for this patient. And this is, I think, happening in many fields, and it should be utilized in anesthesia as well.
Yes, we are trying to, inshallah, hopefully, with the help of the IT department and our own data.
I think what Dr. Jadan mentioned is maybe very helpful for the pharmacist, especially the clinical pharmacist. If the machine is fed with all medication that is received by patient, and you need to add a certain antibiotic, the machine should calculate all the medication, the dosage, the duration, the interaction, review the history of the allergy. I think there is a very good chances for the pharmacist to be able to use the artificial intelligence. Thank you.
Thank you.